So let us start today's program with the first presentation is by Dr. Somnath Mukhopadhyay. He will be telling a case, a butchery tale. Over to Somnath.
Thank you, sir. Thank you for this opportunity. And good evening, respected teachers. It is very difficult to present anything before you, before this learned audience. Today, it is a story of a 43-year-old gentleman. So, am I visible? Am I audible and visible?
You are audible, but you need to share your screen. You are visible and audible, personally, but you start sharing your screen.
You are sometimes visible, sometimes audible. Sometimes both.
Oh, no, sir, I am just stopped my video for
মাঝে মাঝে তো দেখা পাই চিরদিন কেন পাই না
না স্যার দেখছি
সবাই কাব্য করলে তো
ফাল্গুন মাস পড়ে গেছে বুঝতে পারছেন না
হ্যাঁ বসন্ত তোমার বসন্ত জাগ্রত দ্বারে
বুড়োদের বয়স বেড়ে গেছে রাস্তার কুকুরদের মতো বিহেভ করছি আমরা
So now is it visible?
Yes.
Very well.
So let's listen the story. It is a story of 43-year-old gentleman who is a diabetic.
Can you make it full screen?
ঠিক আছে শান্তনু, it's okay.
No problem.
না একটু বড় না হলে আমাদের চোখে দেখাটা একটু ডিফিকাল্ট হয়, বয়স হয়েছে তো বলেছি 8টা 10
Yeah, you carry on. Next slide.
He is diabetic. He is non-smoker. He presented with neck, left arm, and left hand painful swelling for 10 days. Local doctor managed in the line of cellulitis. There was no history of local wound, catheter insertion, or instrumentation, and he attended my clinic due to unresolved, rather increasing swelling. Here it is the swelling of his left hand as well as left side of the neck.
No past history of COVID.
No past. This is other salient points are he is butcher by profession. Chicken shop is there. Irregular on oral hypoglycemic agents. No similar past history. Both COVID-19 vaccines were taken. No history of recent fever, cough, or shortness of breath suggestive of COVID-19 infection. Regarding physical examinations, normal hemodynamics, normal general survey, except cervical lymphadenopathy, more in left, and oral ulcer, buccal mucosal ulcer, some ulcers. Chest, CVS, and abdomen examinations are within normal limits. No relevant points in other systemic examinations, and ECG was sinus tachycardia with enlarged LA. Now, on local examination, he has swelling in his left side of the neck, cervical lymphadenopathy, and left hand swelling. This is the prominence of supraclavicular fossa, left side. So differential diagnoses are SBC syndrome, thoracic outlet syndrome, Pancoast tumor, lymphatic obstruction, cellulitis, necrotizing.
Somnath, you go back to one picture back, please, where you are showing the neck vein.
No, sir, not neck vein, not neck vein.
Before.
Well as
before. Yes. Yeah. Here you see the very prominent jugular venous. This jugular vein is very prominent.
Absolutely,
and appears to be non-pulsatile.
Absolutely, sir.
Okay, chalo.
So from this slide, from this picture, you can see that the provisional diagnosis must be jugular venous thrombosis. Yes, sir. Absolutely. So after this differential diagnosis, the most prominent diagnosis is DVT, axillary vein DVT, as well as jugular vein thrombosis, axillosubclavian venous thrombosis, and maybe brachiocephalic venous thrombosis. Now the investigations are uncontrolled diabetes, 220 and 400 fasting PP, normal KFT, uric acid, just raised cholesterol 218, normal triglycerides, and normal liver function test. Other investigations are euthyroid, HbA1c 11, hemoglobin 16, platelet 2.42, normal ESR, raised CRP 87.4. Investigations: ANA negative, rheumatoid factor 7.2, P time 14 seconds, APTT 32 seconds, and D dimer 2.5, 5 times less than upper normal limit. And I am also thinking of DVT. Echocardiography, that is normal. Grade 1 diastolic dysfunction is there only. Ejection fraction is 57%, no RWMA. Moreover, right ventricular function is good. There was no RV hypokinesia or anything like pulmonary arteries are also normal. Now, venous Doppler study, I told the patient to go for a quick venous Doppler, and the radiologist madam told me that it is left jugular venous thrombosis along with axillary venous thrombosis. So I started managing the patient.
No, just 1 minute. Just Somnath,
yes,
go back.
yes,
and there
yes,
is some lymph nodes. Let's see.
Yes,
Multiple
yes.
matted
Maybe
enlarged
possible.
lymph node. Suggested thrombosis with the lymph node. Lymph node is very important. Okay, chalo. Next.
Yes. Next, the management. So I started managing the patient with, I first counseled the patient that he must have catheter-based treatment. Patient and his relatives are counseled about this catheter-based treatment, but they are unable to bear the cost and opted for conventional anticoagulation. Injection LMWH 60 milligram twice daily was started, and considering the lymph nodes, considering the infective etiology, and also the secondary infection, I started Dalasin C 300 milligram 4 times daily, and blood sugar control was done. Yes,
don't
sir.
write the brand names.
Sorry.
Is it clindamycin?
Clindamycin 300 milligram.
Why don't you write?
Sorry,
Yeah, clindamycin.
sorry, sir. It is a mistake.
What was the total count?
Total count was normal.
Normal.
Yes, sir. Initially it was normal. After that, I will show it was normal. Blood sugar control was done with subcut mixed insulin, paracetamol, PPI, chimoral fort and statins are given. And after that, I searched for occult malignancy, especially in the lungs.
The thrombus, Somnath, the thrombus was organized, no?
Sir, initially I didn't comment about the thrombus because I have just an USG in my hand, and USG is not so typical to evaluate the thrombus. So I told the patient to go for a MR venogram or invasive venogram or CT venogram, but initially they couldn't afford. But after that, I managed the thing. I am telling that initially the search was for occult malignancy in the lung, CT thorax by CT thorax, and carotid sheath assessment by CT neck. And MR venogram or invasive venogram was advised. And it was very difficult to assess protein C, ACE, factor V Leiden, lupus anticoagulant, antithrombin 3 deficiency, as those results could be hampered due to anticoagulants initially. As per my hematologist friend, they told me that go for those investigations after some time, after 3 months or 6 months. And after 5 days, patient and relatives stated their discomfort of having low molecular weight heparin injection, and I switched the treatment to NOAC. Now, this is my CT scan chest, which is normal. CT abdomen, I also searched for malignancy. It was normal. It was done from Medical College, Kolkata. This was my original prescription initially, where all the things are written. And then I go for CT scan and requested Dr. Unup Sadhu for a CT venography if possible. Now, this is the CT venography. This is the, you can see the right side lower down pictures, the 2 pictures where you can see the left jugular venous thrombosis along with left subclavian venous thrombosis, which is extending to left brachiocephalic vein also. Now, this is the diagnosis as you are asking, Soumitra sir. Now, Dr. Sadhu told me that it is a organized thrombus, left jugular and subclavian vein. That is the important thing, that is already organized. Yeah. So after around 1 week, 10 days treatment, there is some improvement. The patient's swelling of the hand is reduced, and neck glands are also reduced, and also their prominence and redness also reduced. So the inflammation subsided to some extent. This is an important thing that is called Urschel sign or Urschel sign. That is a typical of this type of upper limb venous thrombosis, where superficial veins of anterior chest walls are prominent. This is called Urschel sign. This is a typical and pathognomonic of this kind of thrombosis. So I searched for the etiology. What should be the etiology of this patient? The causes, the list, I was dependent on Medscape for the list, and the causes of internal jugular thrombosis are like that: central venous catheter, Swan-Gonj, or any IV drug abuse, or any Lemierre syndrome. Lemierre syndrome means oropharyngeal infection or retrotonsillar, posterior tonsillar infection, which may cause this type of jugular venous thrombosis, but there is associated fever, high-grade chills, fever, trismus, jaw pain, but those are not present. Other DDs are deep neck.
Somnath, they didn't mention about the pacemaker implantation, no?
Here
Whatever
not.
cases I have
This
seen
is
are all following pacemaker implantation.
Yes, sir, absolutely. I have mentioned the thing in my following slide. I'm coming to that slide. So other DDs are deep neck infections, necrotizing soft tissue infections, neck dissection, surgical complications, head neck malignancy, distant malignancy, producing hypercoagulable state. The primary things like protein C proteinase deficiency, antithrombin 3 deficiency, factor V Leiden mutation, jugular bulb catheters, any neck surgery, hyperhomocystinemia, neck massage, polycythemia, and spontaneous causes like malignancy. And as Soumitra sir is telling that secondary etiology of axillosubclavian venous thrombosis are pacemaker leads. That is an important thing, and there are several cases in our medical colleges like NRS and Soumitra sir's. There are also some reports that pacemaker leads are causing this type of venous thrombosis, but in this case it is not there. Hemodialysis catheters, clavicle fracture, chronic central venous catheter placement, all long-term feeds, prone position in surgery, and lung cancer malignancy, especially Pankos tumors are the important causes. So the controversy.
Somnath,
what
you told
yes,
he was a butcher. Was he right-handed or left-handed person?
Yes, sir. He is right-handed. He is right-handed butcher. Absolutely, sir. So what could be the etiology? Is it a primary one, or it is a diabetes mellitus leading to hypercoagulable state, or underlying hidden infection followed by thrombosis? But the certain thing is profession. Being right-handed butcher, excessive use of left-hand abduction from shoulder joint may precipitate the situation. Malignancy and hypercoagulable state should be searched for further management again and again. So controversy is what should be the etiology? It may be a case of effort-induced thrombosis like PSS, Paget-von Stottar syndrome. This is a rare case of DVT. Paget-von Stottar syndrome or primary axillosubclavian venous thrombosis or effort thrombosis. Nowadays, it is the name. It is very rare, 1 to 2 in 1 lakh population per year. Male preponderance 2:1. Young athletes are more susceptible in their 20s and 30s. And there is right hand preponderance. Mind that they are actually the usual situation is that they are right-handed. In 1875, Sir James Paget described this first, but he incorrectly described vasospasm as etiology. In 1884, von Stottar postulated occlusive thrombus, and in 1949, Hughes coined that term of Paget-Stottar syndrome. And what is the pathophysiology of this PSS? That is virtuous triad, multifactorial compressive change of vessel wall, stasis of blood, hypercoagulability, anatomical factors like anomalous subclavius or scalenus anterior, cervical rib, long transverse process of cervical spine, anomalous insertion of first rib, congenital fibromuscular band, narrowing of costoclavicular space due to depressed shoulder, stress from exercise temporarily causes hypercoagulability, and repetitive shoulder arm motion causing microscopy intimal tear. And he is butcher for last 15 to 20 years. So that may be a reason for this thing. And why we are discussing this thing? Because of this importance, in this can complicate the situation. And you have to diagnose it early, you have to manage it early. Otherwise, the risk associated with axillosubclavian venous thrombosis are: first is pulmonary embolism that can occur in 20 to 30% patients in different studies. But the most recent study is telling that the risk of pulmonary embolism associated with ASBT is around 2.4%. So it was initially thought that it is huge. It was huge, But recent studies are telling that it is not so huge, 2.4%, around 2.4% in recent studies. The other complications being recurrent thrombosis, post-thrombotic syndrome with persistent pain and swelling in the arm, stroke, chronic venous insufficiency, pulmonary hypertension, right-sided heart failure. In very rare cases, the affected arm may need to be amputated. And in jugular venous thrombosis also, there are some complications like subclavian thrombosis, superior sagittal sinus thrombosis, SBC syndrome, BIH, idiopathic benign intracranial hypertension, laryngeal and lower airway edema. Moreover, if there is infection associated with jugular venous thrombosis, then it can go to systemic sepsis syndrome, septic emboli to lung, liver, and many other organs. Empyema, septic arthritis may be resulted. Renal failure, hepatic dysfunction, cerebral edema are the other complications. So what should be the treatment? Treatment should be thrombolysis. So in different studies, they are telling that the initial thing that should be performed that within 5 to 7 days, catheter-directed thrombolysis. So you have to do a venography, you have to go for a catheter-directed thrombolysis. If the patient has come within 2 weeks, try for 14 days, though it is better to go for within 5 to 7 days, but you can do this up to 14 days, and followed by anticoagulation to maintain INR 2 to 3 with warfarin for 3 to 6 months. Next is the literatures are telling that catheter is to be embedded in thrombus, urokinase infusion with loading 2.5 lakh international unit, followed by 4,000 international unit for first hour and 1,000 international unit for next 24 hours is the primary mainstay of the treatment, and heparin infusion at the rate of 800 international unit per hour to be given, and monitoring to be done with fibrinogen level at least 80 to 100 milligram per DL. And if needed, balloon dilatation and stenting may be done. Now, considering the endovascular treatment, suction thrombectomy with angiojet system is the mainstay of treatment. But recently, first procedure of choice is becoming surgical thrombectomy. And the pharmacomechanical thrombectomy appears to be effective in PSS also. And subsequent thoracoscopic or open surgical decompression of subclavian vein may be considered for other further managements. So, what are the indications in this patient to send for surgery? So, indication for surgical treatments are presence of an anatomic anomaly such as anomalous subclavius or scalenus anterior, congenital fibromuscular bands, or narrowing of the costoclavicular space from depression of the shoulder, rethrombosis of the vein after previous thrombolytic treatment, endoluminal stent placement to prevent stent fracture from compression against the first rib. And the possible forms of surgery are like embolectomy, you all know, bypass, first rib resection by transaxillary or supraclavicular approach, or medial subtotal claviculectomy. In this patient, no anatomical abnormalities are found, but cervical lymphadenopathy from infective etiology may be the factor why the patient suffered from type of situation. Whatever be the thing, the improved reports are there subsequently. Sugar is controlled, normal KFP, sodium, potassium, CRP came down to 9. And as Dr. Anjala Datta sir is asking that throughout the event, throughout this situation, his total leukocyte count remains normal. It is the 17th February report. It is 7,500. Hemoglobin is 15. Platelet count is 2.38. ESR is 28. And I am following up the patient. He is doing fine. So the controversies are, first one is, what will be the prognosis? I didn't give the patient the definitive therapy, that is catheter-directed thrombolysis. So it is my question to you that is there any scope in further management? Whether can I go for catheter-directed thrombolysis in this patient now? Yeah, but it is an organized thrombus as per the report. Second is role of SVC filter. SVC filter is only needed when anticoagulation fails or contraindicated. Third is NOAC. Will NOAC do better or LMW should be continued? I think recent guidelines are telling that NOAC is sufficient. You can give NOAC for 3 to 6 months. How long anticoagulation? Is it 3 months or 6 months or lifelong? Because it can be unprovoked. So I think if it is PSS, that is the most probable. My diagnosis is PSS. So I have to give this patient that 6 months anticoagulation. And after that, the assessment should be done. And when and how to evaluate secondary etiology, because you have to search malignancy again and again, because often some hidden malignancies may precipitate initially by thrombosis. After that, the malignancies flare up. So I have to be very vigilant in this case. But the last controversy of this thing is, should he continue his profession? He has to maintain his profession, whether he will remain butcher or not. That is a very difficult situation. And if he use his right hand in future, then there may be a chance of right-handed axillosubclavian thrombosis also. So my take-home message from this case is, primary axillosubclavian venous thrombosis is a rare disorder and should not be thought initially before ruling the secondary causes out, but must be remembered in appropriate clinical scenario. The unique this case is unique as the age of the patient is 43. It is elderly. The patient is to some extent elderly, and left hand is involved due to his profession. Prompt management focusing thrombolysis and anticoagulants along with antibiotics should be done. COVID-19 infection should not be forgotten as a cause of hypercoagulable state. So also COVID-19 vaccination. If similar cases are reported post-vaccination, then we have to think again. Still in 2020, the history gives the most of the information for diagnosis. Thank you. The patient is doing better and his left turn now normalizes. So thank you for your patient hearing.
Somnath, did you do a repeat venogram or venous Doppler to see what is the status now, whether it has been recanalized?
I have seen the Doppler, venous Doppler I have seen, but it is not actually the thrombus organized, and that radiology madam told me that there are some channels are there, but I couldn't perform any CT venography or MR venography.
See this part very well, because as you are telling, whether you need to go ahead with any intervention there, first you need to see whether how is the channel and how good it is, whether how is the collateral channels before planning anything. That is one thing you need to see.
Okay, sir.
So you need to do a repeat one once the patient has improved. Second point is, Anjana কিছু বলছো?
Yeah. No. Carry on.
Second point is, you said how long you should continue. Is it a provoked? What do you feel? This is a provoked one or an unprovoked one?
Though it is an unprovoked one,
Why do you say it is unprovoked?
Because there is no history of provoke.
No. But repeated exercise or stretching of that part, that can cause trauma to the venous endothelium.
Okay.
That itself is another provocation.
Okay, sir. Okay.
So if you are telling about that part, that it is because of the movement of the left hand, as they do in cases of as happens in cases of the butchers, this is perhaps not unprovoked, but we don't know what is the exact cause. It may be an unprovoked one, it may be a provoked one. So this becomes an issue.
Okay.
So unprovoked, we finish off within 3 to 6 months. But if it is a provoked one, but if it is an unprovoked venous thrombosis, in that case, this is anybody's guess. Ideal thing is they have to continue it indefinitely.
Somnath, thank you very much.
Yes, sir.
Very interesting case presentations. Initially, in the long list of your investigations, you did not mention about the venous Doppler study. The reason why I say, because it's cheap, easily done, and that should have been done on the first list of investigation. Number one. The importance why venous Doppler study should be done, and initially.
Sir, venous Doppler I have done venous Doppler.
Yeah, you didn't mention that in your list. I checked for it. In any case, the second important issue about venous Doppler is simple, less costly. So once the patient is treated, you can follow the thrombus structure, size, hemodynamics, everything by going for Doppler venous study regularly. That will give you a very big important aspect to look for the scenario. In that way, you can keep a watch on the patient. And then finally, although it is very difficult to suggest that it is unprovoked in only 45 years old, our search for the provocation should continue.
So, may I have a few comments?
Yes, sir. Yes, sir. Please, please.
There are certain points. Number one, our history was missing certain things. You are telling that he deals with chicken, not mutton or anything, not turkey or mutton.
Yes.
So why should there be a huge abduction of the left hand if he is cutting with the right hand? I can't.
No, sir. No, sir. That is the thing.
Like that.
That is the crux, sir. That is the crux. If you see a butcher, right-handed butcher, they are actually they are chopping like that and they are abducting like that. Every time they are chopping like that and abducting like that. That is
mutton or chicken.
That is the thing.
Chicken. Are you sure that chicken you need abduction like that?
Chicken, sir. Chicken. That is the thing.
That's fine. Or also you try to find out whether there is any repetitive trauma on that area by an instrument or holding the chicken or holding the instrument. You have to find those out. As Dr. Guha was saying,
that may be a reason.
If you can pinpoint a provocation, then it is very easy to correct the provocation and also to limit the duration. Unless you prove anything provocative, ideally, it should be a lifelong anticoagulation. Einstein or any other studies of DVT, they are not limited to lower limb. Around 10 to 20% cases in different studies were upper limb DVT as well. So their conclusion equally applied to upper limb DVT. And they were with rivaroxaban, with apixaban, you know, all those trials. And particularly rivaroxaban trial was very robust on deep vein thrombosis. And there it is, if it is unprovoked and if it is extensive beyond the superficial, so below knee or below elbow, then it has to be a lifelong unless you correct it. That is number one. Number 2 point is that you have given apixaban, very good. I think it is good. Also, rivaroxaban is good. Though dabigatran don't have that much of backup for DVT. Number 2. Number 3 point is that, as you were saying, whether to change the profession. So instead of changing the profession, you could tell the patient to change the modus operandi of culling, or to keep an assistant or something like that, because it's his bread and butter. So that is another important thing. 4th point is that after it is organized and you have shown a very good trimming of the hand, edema has gone. I don't think you have to intervene any further except in keeping the anticoagulation. More important to prevent a second DVT in any other part of the body, rather than treating this DVT anymore. Because we have seen this with the pacemaker leads, and usually they respond with, as you given the chimeral fort and some kind of but again I will ask Shubhro, if it is a pacemaker lead induced, you cannot really remove the cause. So do you give lifelong anticoagulation?
Yeah, okay. Let's address this one by one. Firstly, Shomnath, it was a nice presentation. It's indeed not a very common cause. Yeah, excellent. But I think let's see one by one. Firstly, what Soumitra said, I absolutely agree. There are 2 things you have to consider: whether there is a removable cause, that is a provocable cause, and whether that provocable cause could be removed. If we are unable to find, then we have to consider this is something which we do not know, and the patient should be preferably given lifetime oral anticoagulation for indefinite period. Next, coming to also you said like you couldn't send the thrombophilia screen or whatever for the test because the patient was already on heparin. I think for any sort of DVT, if there is no obvious cause, for example, the patient had a fracture lying down or whatever, in that case it's best to take the blood sample before you start on heparin. Because once you have started oral anticoagulation or heparin, and if you're thinking of giving them lifelong, you won't be able to really get the window of opportunity to start, to do this test. You have to stop them for a period of time. Thirdly, I would say that, what was your question, Soumitra? You asked me something?
If it is a pacemaker lead induced,
Oh, yeah.
of course
See,
you cannot remove the lead. So will it be a lifelong?
true, but I have several, just like you, I've got a few pacemaker India lead induced thrombosis, but to be honest, I've never given them lifelong, and I've seen many of them actually without doing anything they subside.
Yeah.
So,
Basically, yeah.
yeah, so I really don't do this, but I think probably because we are manipulating at that time, we are taking the lead in and out and trying to position. Maybe that could have actually caused it, and they do not stay.
Maybe.
But one thing I would slightly disagree with you, that dabigatran also has now a lot of studies really regarding.
Yeah, maybe. Yeah, I missed it. Yeah. The matted lymph node, Somnath. How do you explain the matted lymph node and so high CRP? So it is the thrombophlebitis which is causing the lymph node, or the lymph node causing thrombophlebitis. They must be related. You cannot have matted so many lymph node in the neck just on a thrombosis. For the lower leg DVT, you don't see any femoral or inguinal lymph node. So there is some connection with the it may be just due to infection-induced thrombosis.
I was thinking that it's due to infection actually, because maybe the profession is such.
But the counts are not raised at all. ESR is not raised, and the
CRP was raised.
CRP was raised actually.
It could be viral. It could be a viral.
It is very difficult. It is very difficult
to say.
As
Soumitra was telling that this can be a thrombophlebitis. That an inflammatory component, and that's why the CRPs and other things are elevated. That is possible, but most important story hidden in this case is we sometimes find it, which was partly discussed right now. We sometimes find it in patients with a permanent pacemaker. That is exactly where its importance lies. And what should be done in those cases? Shubhro said that in most of the cases in some cases he didn't do anything, and it's settled. My experience is exactly similar. Even in the earlier stages, we didn't give even anticoagulants, to be very honest, because NOACs and other things were not available at that time. And initiating a VKA for this reason, we were not very sure. I'm talking about our younger days when we started doing pacings and all. At that time, we just did not do anything. And these patients usually, all of them settled. All of them settled because of the development of either recanalization or development of some other channels by which it diverted the blood. Initially, the limb which was swollen, it settled in most of the cases. But in this perspective, I just like to share one personal experience of mine. One case I had, a permanent pacemaker replacement. While doing it, we found that there is a kinking and there is an angulation in the lead inside toward the bottom of the right atrium. And after doing some manipulation, I found that it is not there. That means it was almost torn, and it took a very peculiar turn. The one was hanging in the right atrium, the lower part, it fell and went into a tributary of inferior vena cava. What to do about that case? I published that particular case, and I do have those photographs till now, perhaps. That is one case, because if you remember our oldest pacemaker leads, that the inner core, it protrudes because the outer cover, it will be somewhat retracted and the inner core protrudes, and that is metal, that is thrombogenic. That is one case I went on giving anticoagulation for a very long time. At least it was she was a very senior lady, and I continued it indefinitely. Used another lead for the pacing. Fortunately for me, nothing happened with anticoagulation or giving anticoagulation. Nothing happened, and perhaps there could have been some embolic manifestation if I wouldn't have gone for oral anticoagulation. I gave acid.
But I have a point to make, sir.
Sure.
May I? Yeah. The points are very well taken. Most of the cases of upper limb DVT related to pacemaker implantation, they do not require any intervention. But I have a experience in the form we published it. There are 20 case series of upper limb deep vein thrombosis. It was published in Pacing and Clinical Electrophysiology Journal, PACE Journal. By this time has more than 50 citation, I think. So what we did, we gave only, at that time NOACs are not that available, so we gave only I think six month of warfarin or oral warfarin and acetrom, and majority of the case they actually responded. So the question from Dr. Soumitra Roy is, because we cannot take out the lead will be there, how the thing that short course of anticoagulation works. Actually, you mentioned also the alternative collateral channels they develop. So initially the thrombus burden is high. If you just take care of that, by that time the collateral channel develops, and that actually serves the purpose, and edema and all are gone. And regarding the case, this is an excellent case, but one simple question I'm not being able to understand, how the person who is a right-handed butcher is developing thrombus on the left hand. That is, if Somnath can elaborate that, I could not get the points.
I think you joined a little late.
Actually, I elaborated already. I elaborated actually.
Reflecting your hand goes up.
Yeah, I listened to your point, but I could not get that.
And the left hand goes up. Left hand goes
up. Yes. So
actually,
if the left hand
in his right hand, and left hand he abducts like chickens, like the bones.
While you are tearing off the part of the chicken.
Yes, tearing off the part, and the hand.
Exercise following surgery.
So every time he's chopping and tearing off.
One point I want to make.
Yes, sir.
That this is very interesting. All of us had the same situations. Venous thrombosis on the implanted hand. Thrombosis is confined to the local part, and most of the thrombosis is clinically evident within 1 month of the implantation, not after 1 year or 2 years. And all of them responded well with medical treatment. Even to that extent, I had a patient implanted, and I was going to replace the pulse generator. The party, a little bit learning of medical science he had, insisted me to take out the old one. So while taking out the old one, I find that the insulation coming out, and the inner layer of the wire is still stuck to the right ventricle. So I was absolutely in two minds what to do. In any case, I just cut off the insulation, tied it there, and put the new lead, kept the patient on NOAC for 6 months. Still, touch wood, the patient is not having any complications.
So, sir, when to repeat any CT venography? I have done venous Doppler.
I would request you to get yourself acquainted with the Doppler study, ultrasound.
Yes, sir. I have done.
You can do the ultrasound study number of times without any cost, without any other hassle.
Yes, sir. But it is very difficult to comment. The radiologists are telling that
it is difficult to comment from the first report. But if you follow it up, because your patient, you can make out the differences.
Somnath,
I have a small suggestion in this.
Whether in sports medicine, the javelin thrower or short put throwers do develop this, because conceptually they are more prone to develop.
Actually, there are the case reports are with the athletes only. The case reports are mainly with the athletes in their 20s and 30s, and there are several case reports of judo players and karate players.
Yes,
where the sudden abduction movement that can do this type of PSS.
Yes.
I have a small suggestion, Somnath. Can you just do a very simple thing? Take a venogram. Just venogram in cath lab is very, very cheap. It doesn't require, because you can arrange it probably without any cost.
I can arrange.
Just get one venogram that will give you, a lot more of information, because we are more accustomed in seeing venogram and angiogram. We can understand what is going on, and you can actually plan for future intervention if at all they are needed. Fine. Just get one venogram and share it in the group so that we can also get the insight.
Sure. Let's go to the next.
We have discussed this thing enough. Just one take-home message. Shomnath, you please
Yes, sir.
give the take-home message, because this thing is going to happen with pacing much more often than your case. So if a patient develops swelling of the arm ipsilateral to the pacing, what should be done? Usually this occurs a few weeks after the implantation of the pacemaker. That is the usual thing. So what should be done? Give a short course of anticoagulant,
Yes.
do nothing, or anything else? Start any third
Short
option.
course of anticoagulant should be done.
How long?
Short, up to 3 to 6 months, 3 months or 6 months. Because if you are getting that thrombus and you are doing nothing, you cannot justify.
So let us take this as a take-home message that these patients should get a short course of oral anticoag, NOACs or something, whatever it is, and you can go ahead with anything.
Another thing, sir.
Rivaroxaban or dabigatran, even as Shubhra has
Another
said,
thing, sir,
dabigatran has enough literature
again,
now.
the dose must be initial dose must be like that, 15 milligram to, twice daily for rivaroxaban. It is 15 milligram twice daily for 21 days, followed by 30 milligram OD. Or in case of Epic-7, it is 10 milligram twice daily for 7 days, followed by 5 milligram.
That is for acute pulmonary embolism, not for prevention.
Sir, that is.
This is a.
But how can I?
No. This patient doesn't have any pulmonary embolism. Why you go ahead with such a high dose?
No, but it is the same for acute DVT as
actually,
well as pulmonary
it
embolism.
is the same, sir, because I am dealing with brachiocephalic venous DVT. So
that is the basic difference. This is a
It's not prophylactic.
Thrombosis, another is thrombophlebitis.
No, we are treating. We are not. It is not prophylaxis.
I think antibiotic is also important in such cases.
This is a,
yes, sir. Yes, sir.
Not a phlebothrombosis. This is a thrombophlebitis. That it causes. That is an infective element. That is an inflammatory element. Is very much there. That adheres it to the wall. So, in chances of dislodgement and pulmonary embolism is much less in this type of cases rather than in phlebothrombosis as we get in patients with stasis and all.
Okay, sir.
Okay, anyway, if whatever is there, literature says it is double the dose, you let us continue it for 3 months and take it off.
Yes, sir.
Okay, thank you very much, Shomnath.
Thank you, sir. Thank you, sir.
Very good discussion. Next case is Shupratip. You are there? Shupratip will be describing a case of thrombosis with IVAS guidance. Shupratip, please.
Yes, I'm just sharing my screen.
May I request everybody to please open up the video so that we can see your faces. This is another forum where we can at least virtually meet.
Are my slides audible?
Yeah, visible. It is visible. Well visible.
Yes. Okay. Okay. Let us start. Good evening, sir, and good evening, everybody. This is a case of stent thrombosis, and I will discuss the importance of IVAS guidance in this case. And this is the story of a 62-year-old diabetic male who presented with one episode of severe chest pain along with sweating 7 days. For last 7 days, he has the most significant episode 7 days ago, and patient had history of similar type of chest pain 4 months back, for which initial coronary angiography was done. Coronary angiography at that time revealed an eccentric lesion in proximal LAD, and PTCA2 LAD was performed at that time, but the patient had recurrence of chest pain on minimal exertion from 2 months onwards. Anti-anginals are added, but only with partial relief. At the time of presentation to me, ECG revealed anterior wall MI of some duration. LVEF dropped from 50% to 35% with hypokinetic entire LAD territory. patient was in heart failure, having rest angina and postprandial angina. So we stabilized the patient and took him for cath. So this is.
You have not mentioned about the medicine he was taking in terms of antiplatelets or anticoagulants.
Patient was taking ecosprin, ticagrelor, atorvastatin on all the medicines. I have repeatedly asked him whether he has missed any dose or not, but he told me that he hasn't missed a single dose. So patient was on dual antiplatelet. He hasn't missed a single dose. So this is the aleocaudal view showing which reveals the thrombotic occlusions of ostial LAD with significant ISR of LAD stent. I have a suspicion that there may be diffuse involvement of left main, and the LCX is a large, probably codominant vessels with relatively spared ostium.
Where is the stent, Shubhdeep?
Yes,
From
yes.
which part? Is it an osteoproximal stent?
It is from the ostium. It is LAD ostium.
So inside the stent, you are saying both thrombosis and instant restenosis, both.
Yes, thrombosis and instant restenosis, but only 4 months. So it may also be thrombosis only. So this is the
because actually, Shubhdeep, these are two absolutely opposing conceptually. The milieu which promotes thrombosis and the milieu which causes instant restenosis are totally North Pole and South Pole.
Are different.
It's very difficult for them to coexist. Anyway, chalo.
But
yeah, Ayvaz will give us the answer. Ayvaz, please go ahead with the case.
Yeah, let's finish first.
so stent was placed just after this crossing of this branch, and there is significant ISR in the proximal 1/3 of the stent. I think it is ISR. Possibility, I am not sure where the healthy zone is, and I think there is a healthy zone near the confluence of septal and diagonal. So in this view, in this ariocaudal view, we think we have seen there is a diffuse involvement of left main, and the angle of entry from LM to LAD was quite stiff. This is the RCA short, and the good thing about this is the RCA is also codominant vessel and free of significant disease. So we reviewed the previous CD for proper planning. It is the now we can see the angio of the previous angioplasty and angio CD. So this is the first angio CD, and this shows there is a long segment lesion in the LAD starting from the ostium with significant stenosis just before the first diagonal. And LCX is in this case also large codominant LCX without any significant involvement of ostium. And one important thing is the size of left main is quite same as LCX. So there is an eccentric plaque for which PTCA was done.
What is the stent?
No, sir. This is the angio first time PTCA. This is the angio first time PTCA.
Yeah, the first time PTCA stent must be seen.
This is before stenting.
It is before
It is before stenting. It is before stenting.
Carry on.
So from this epicranial view, we are not sure about the distal landing zone, and we have a confusion whether we should take a short stent or long stent in this case? And third important thing was, is left main involved or not? So in this case, also LAD LCX bifurcation is at angle of 90 degree. And if we see the landing zone, there is a haziness after the lesion, and so we are thinking about long stent in this case. Now see the PTCA. In this case also RCA was previously was quite free of significant disease. Now we are moving to the angioplasty video in the first angioplasty video. So initially wiring was run through NS. In that case, pre-dilatation was done with a 2.5 into 12 SC balloon at 12 atmospheric pressure. And after the pre-dilatation, there is slow flow with distal migration of thrombus. And then they have took a 3 into 24 days. It is positioned in the LAD. This is the position. And here the stent is 0.5 millimeter after the marker. It was the distal landing zone in that case. Stent inflation was done at 14 atmospheric pressure for 20 seconds. And post-stenting, we are not sure whether stent was present in the ostium or not. So here in this case, post-dilatation done with 3.5 into 10 NC balloon at 10 atmospheric pressure. And this is the final shot in that case. And I have a notion that there may be possibility of left main involvement. And second important question, whether they have missed the ostium in that case. So for this, we have taken the IVAS guidance. These are the questions which we need to answer before going for PTCA and before the planning. So the issues regarding the next PTCA was, what is the mechanism of stent thrombosis? What is the size of the stent which we should choose? Is left main involved? Is there any involvement of LCX ostium? And what is the extent of involvement of left main? And what should be the distal landing zone? These are the questions we should answer.
Supratik, one issue.
Yeah.
Okay,
Yes,
carry on.
Yeah, before you move on, Supratik, fantastic case. So let me make two important observations. As you mentioned, left main is looking, in fact, similar size or even smaller than LCX. That clearly indicates that left main is definitely involved. Without doing an IVAS, you can get this information. Now, second issue, you mentioned your position in the left LAD ostium, the stent, and 0.5 millimeter beyond the dot the stent is starting. That clearly indicates that the LAD ostium was not covered. Our rule of thumb, whenever you are doing angioplasty to LAD ostium, at least one stent should be in the left main. So clearly in this case, the LAD ostium was not covered, and this was actually ideal case for IVAS in the primary angioplasty, because otherwise you can never understand what can be your proximal landing zone. Distal, I'm not much bothered, but proximal landing zone is very important in this case. Please go ahead.
Especially when you
just go back one slide where you issued the out. What is the mechanism of stent thrombosis? Just now you said whether it is a stent thrombosis or it is a stenosis, you are not sure. How do you make this point? That is one.
No, I want to see whether there is any
You said it is a restent, whether it is an instant restenosis or it is a stent thrombosis. Soumitra, as he was telling, these things are totally different.
No,
This totally different. But there are two types of things: neointimal hyperplasia, and over that, neoatherosclerosis and stent thrombosis can occur. Number one, and number two, there may be possibility of leaving some bare zone in ostial LAD, where there may be possibility of plaque rupture and stent thrombosis can occur. And the third important thing, there may be under expansion of stent. And these are the
Fine.
things.
What was the presentation? Presentation, if I can gather, it is not very acute. How was the presentation?
It was acute initially.
The 4 months ago, 4 months back.
Initially, 4 months back, patient presents with 1 episodes of chest pain. At that time, EF was 50% with hypokinesia of distal septum, distal apical septum. So they go for angiography. They find an eccentric plaque in the LAD. They stented it. Just after stenting, after 2 months, patient was initially relieved, but after 2 months, patient started having chest pain, severe chest pain, even with rest.
It was like ACS. The second time, it was like ACS.
It was like ACS. It was like ACS. And when patient came to me 7 days ago, patient had severe chest pain, and the patient came to me with some amount of failure, some amount of orthopnea, chest pain, postprandial angina, all these things.
Besides the point. But if the patient had an ACS-like picture, then of course this comes up. Carry on.
Yes, see, this is stent thrombosis. Whether it was superimposed on a ISR or not, I think that's a question which your IVAS would say.
Yes. And the chance of ISR is less because only 4 months old state, only 4 months. But I also want to check whether they have leaved a plaque where there is plaque rupture occurs at the ostium, or some amount of malapposition is there, some amount of neointimal hyperplasia, or there is thrombus in the stent. I want to look for that.
Carry on, carry on.
So initial wiring was done with cyan blue, and one important thing was wire crossing was easier than expected. It was very easy, as if I am doing wiring with some acute lesions. So I'm a bit scared. That's why I am not able to do the IVAS before the dilatation. So initially I dilated it with 2.5 into 10 NC balloon at 14 atmospheric pressure. And this is the results after pre-dilatation. And fortunately, there is no pinching of LCX ostium. And then we take first IVAS run in LAD. And this is the IVAS, and now first I move it to the distal vessels, and if we see that the distal vessel is of size 1, 2, 3, it is around 3 vessels, 2.75 to 3. Then as we move upward, here comes the confluence of that septal and diagonal, and here the artery size, I think it is quite large. It is at least 1, 2, 3, and 4. It is at least about 3.5 to 4 artery, and it is relatively free of significant plaque burden here. Now gradually, as I move upward, there are some amount of plaque. So gradually I pull my IVAS, and from here the stent starts. Now if we see here, the stent as compared, artery is quite big as compared to the stent. So it is almost about 1, 2, 3, and 3.5 to 4 artery, and the stent is looking under expanded here. Now, as we move upward,
What was the stent size used?
it was 3.3 into 24 stent initially, followed by post dilatation with 3.5 balloon. 3.5 balloon and probably at 10 atmosphere pressure or like that. I think there is some amount of neointimal hyperplasia is there, but it is not that much. Gradually, I am moving upwards. There is some amount of neointimal hyperplasia on 9 o'clock position, but it is unable to explain this. Here, in this view, we can see some amount of neointimal hyperplasia. And the stent in the proximal part is quite expanded, and this is the junction of LAD and LCX, and here you can see there is stent strut. So the stent strut is just at the junction of LAD and LCX. And if you move upward, then this is the junction, and the stent strut is only at the lower border of LCX, and here it is LM, and there is significant plaque burden in the left main. So this is the aorta. I have some difficulty while I am pulling my IVAS catheter, because the often the catheter is engaging and it is very difficult to pull the IVAS catheter. So I initially pull the catheter and then push the IVAS. And in this view, you can also see when I am entering from aorta to LM, there is plaque burden. So I have an impression that LM ostia is involved. I have checked it again and again to see whether there is ostial involvement of LM. So from this view, it is quite sure that LM ostia is involved. So from this IVAS, we gathered the information that distal landing zone is near the confluence, four vessel in the distal landing zone, LAD stent is in the ostium, but one important thing, I am not able to see any evidence of plaque rupture in the ostial LAD. So next thing is wiring of LCX and IVAS pullback from LCX to LM to see whether there is any ostial involvement of LCX or not.
Supradeep, can it be made full screen or you missed the video?
Sir, for IVAS video, I can make it full screen, but in that case, it is difficult to run step by step.
Okay, carry on. Carry on.
Sir, is it okay?
It's okay. It's better.
Okay. And this is the IVAS run from LCX to LM. And next, this is the IVAS run from LCX. And Now, if we see this, then we gather this information that LCX is a large vessel, ostium is with relatively less plaque, and LM with diffuse involvement with plaque ostium. And this is the wire in the LED. This is the wire in the LED, and here we see there is diffuse involvement of left main. And we have cross-checked it. So this is the aorta, and from there again, we again cross-check it. Now this is again LM ostium. This is the involvement of LM ostium. So we have decided to put a stent in the LM ostium. So we have repeated the pullback once again to be sure whether the LM ostium is involved or not. This is the same picture. Actually, I have repeatedly cross-checked that where to put the stent, because I am not at all sure that whether LM ostium is involved or not. This is the wire in the LED, and now the LM start. This is aorta, and from here again we push the IVAS catheter and we check for the ostial plaque in LM. So we took a 3.5 into 38 Giants expedition stent, and the distal landing zone we put near the confluence of septal and diagonal. This is the initial stent positioning.
So from initially, the initial stent was 2.5.
Initial stent was 3 into 24. Initial stent was 3 into 24.
And this one?
3.5 into 38. So this is ileocaudal view was taken for proper ostial covering. I inflated the stents at 11 atmospheric pressure because I was a bit skeptical about the distal dissection. I go to nominal. LM ostia was appropriately covered. This was the view. And after stent placement, we have done third round of IVAS, and the distal part was in a plaque. So we decided to take a little undersized balloon. In compared to the actual diameter of the artery, we have taken a 3.75 into 8 NC balloon and go up to 12, 16, 20, and 24. That means 12 in the distal most part, followed by 16 in the mid part, then 20 near the LED ostium, and 24 in the LM. So these are the balloons, and then finally we post dilate left main and ostial LED with 4 into 10 balloon at 20 atmospheric pressure. Ostial flaring was done. So this is the final result. Final result. And
Sarcostium was like that before.
yes, sir.
Sarcostium, was it like that before?
Yes, sarcostium was not significantly pinched. And this is the epicranial view. final shot, and this is the final IVAS run. And from this IVAS run, there are certain things. The distal zone is in plaque, but there is no distal dissection. And no malapposition of the stent. The stent is optimally expanded, and the and last, I want to show one thing. The LM ostia is covered. LM ostia is covered properly. So just last, to conclude this case, I have forgot to see one thing. I have a question. Should we open the strat of LCX in that case? And I think I have forgot to look the LCX ostium in that case for any gel stat, and I think we'll look for it in the next time in a similar type of case. Thank you.
Excellent case. So Pradeep.
Thank you, sir.
So yeah, can I make some comments?
Yes.
If you can please unshare so that we can see each other.
Okay.
So this was a fantastic case. IVAS gave us a whole lot of information. So one of the important information is that the stent was undersized. Now, how we look into the matter, there are two possible mechanisms of restenosis. One is neoatherosclerosis, another is neointimal hyperplasia. So in IVAS, if you get speckles of calcification, that actually favors neoatherosclerosis. If the calcification is not there, probably it is neointimal hyperplasia. Now, in your case, actually it was an undersized stent. And whatever things we observe, either mostly there was hardly any calcification. Mostly it was neointimal hyperplasia. It was outside the stent margin. So the pathology here was not restenosis, rather undersized stent, which actually led to the problem. And in the IVAS pullback, we could clearly see the ostium of LAD. There was hardly any strut. So ostium of LAD was missed. And as we expected from the angiogram runs, the left main is definitely involved. It is definitely involved more than 50% stenosis. Ostium was definitely critical. You did repeated runs, and it was clearly seen that ostium had critical stenosis. So you did the very nice job to cover the ostium as well as cover the whole stent. Only two things I'd like to mention here. As the previous stent was undersized, so I thought that the breaking the previous stent with the NC balloon of 3 millimeter at high pressure, or taking a OP and NC kind of balloon would have facilitated the issue. And there is a very common trick of doing left main stenting. When you are planning to cover the left main ostium, a third wire needs to be hanged in the aorta, so that your catheter do not go inside the left main and the left main ostium is properly covered. So that is one trick. I did not see that, but that we can actually do in future. Only thing in the post stent IVAS I'd like to mention, the stent was not properly apposed with the left main. I could see the left main was not properly apposed. So here I would like to mention very simple thing regarding the choice of stent. The 3.5 was a perfect choice in your case, but rather than taking a giant stent, here I would have preferred a Terumo Ultimaster or a Boston Scientific Synergy stent, which can be expanded to the larger extent, particularly in this case, because there is, the LAD and left main are not of similar diameter. So probably your LAD was a 5 millimeter vessel, what you could get. So if you can only do that with a synergy or Ultimaster stent only. So I would have chosen either one of them.
There is a question. First procedure, as you showed, thrombus migration, there must have been laminar thrombus, which later dissolved to cause a malapposition.
There
in the
is
chat box. Yeah.
but I don't think there is significant malapposition. It is mainly under-expanded stent in our case.
Yeah, could I say something now? I think, see, if you look at the LAD and you look at the left main, then it's quite, it appears that the LAD is, the size is actually bigger. I mean, have they had done a IVUS initially, they could have measured the true dimensions of LAD. And that's why the importance, that's where the importance of imaging is. The left main certainly cannot be that size because it's at least would be larger than the circ. It wasn't. And the LAD, most likely it was a very diffuse disease. I don't think it's a laminar thrombus was the reason, but it's a very diffuse disease. And since it was not assessed by imaging, so our undersized stent was used and it was underexpanded. And because of underexpansion, as rightly pointed out by Arindam, if you look at the IVUS, it was not really neointimal hyperplasia as a cause of reed stenosis, because whatever we found was not inside the interior to the stent. It was just between the vessel wall and the stent, which was not expanded enough. So this was the reason. So this was actually an underexpanded stent, which led to this sort of problem. And I think the rest of the things Arindam has very nicely covered. So really, I don't have anything to say. But that is the. I think it was an underexpanded stent, and the assessment was wrong initially because the imaging was not used in this case.
May I say one thing?
Just a minute. I think the most important message that should be taken home is utilization of the IVUS prior to PCI at this type of clinical setting. We have left main disease, we have left main ostia disease, we have LAD ostial disease. We are going to do the procedure second time round. So we should, even at the first time, left main LAD, sarc, circumflex, ostia, all these areas can get yourself first much clarified when you're using IVUS in right time. So that is the message. And the rest of the work was done excellent.
What I was a bit confused about underexpanded stent versus underexpanded vessel. The stent, if chosen undersized, and even if it is fully expanded and fully dilated, it will be an underexpanded vessel. So here I think the stent was fully open, but it was unfortunately undersized for the vessel. So that is, it is not an underexpanded stent. It is an underexpanded vessel for the mismatch of the stent vessel diameters. Number one. Number two, I can't see any explanation here for an stent thrombosis. You see, it is a drug-eluting stent. Aspirin, ticagrelor was going on. If the patient was taking it, I hope he was taking it. There was no exposed strut. Everything was rather covered with atherosclerosis, neoentima, or whatever it is. And even this, when you are going through this very soft thrombus, like almost like you are doing a primary angioplasty, you didn't take any protection or anything, and there was no flow, slow flow. The thrombus just vanished after you pushed the wire. The next shot shows there is nothing. Everything is clear. So I was a bit confused about the origin of the thrombus, the cause of the thrombus, and the fate of the thrombus over here.
So I am also not able to see any evidence of plaque rupture in LAD ostium. I am also a bit surprised. but there may be some area in left main where I suspect some plaque rupture, but that is not very conclusive. That part is also unexplained to me. But it was soft thrombus. Wiring was very easy in this case. And I also have one question to Arnamda, that whether you use OPN balloon in this case, because it was quite soft thrombus.
No, I'm not talking about to open the thrombus. I am the stent was implanted 4 months back. So 4 months back, already some amount of epithelialization has taken part. So you are putting another stent. So the previous stent needs to be either pressed into the periphery, or at least at some part may needs to be broken. Otherwise, the new stent may have difficulty in proper expansion. So if your NC balloon does it, that is fine. You can have the guidance from the IVUS. But if it is not successful, normal non-compliant balloon, I would not hesitate to use a high pressure double layered OPN NC balloon. And I agree with you, the IVUS did not show any plaque rupture, but IVUS is not actually a very ideal tool to look into plaque rupture. If you really want to pick up plaque rupture, you need to do OCT.
In a situation like this, Arindam or Shuputik, what is the difference between stent IVUS and stent dilatation prior to PCI and after PCI? What are the
Sir, please again, once again, I am not getting you properly.
You are dilating first you are dilating with the old stent in situ. Then you are putting the new stent and doing another dilatation after that. Do you think that your dilatation in initial stage NC balloon only 10 yes was
14 atmosphere?
Even then, do you think that between your dilatation in the prior to PCI and after to PCI was anything to comment on?
Yes, sir.
After PCI, I have dilated it with 3.75, goes up to 20-24, and then I have dilated it with 4 into 10 balloon and goes up to 20 atmosphere. But prior to PCI, I have just dilated it with 2.5 balloon to make the way of the IVUS.
So yeah, if I take this question, if you really want to cover the left main start, the left main post dilatation could have been even higher side, at least 4.5 I would have gone. And as Dr. Dotto is mentioning, how much bed preparation you have done, you can get a fair idea by doing IVUS pullback, because you do have the machine. So after pre-dilatation, the bed preparation, actually you should do repeated IVUS run to see whether you have enough space for a new stent. So that information you can get from doing IVUS.
May I give a thought process? It's a conjectural to all of you for your comment. As we could not define exactly the cause of thrombus in this case, and we are giving a more thrombogenic milieu by putting another very big stent with raw stent struts. Is there anything thrombogenic going on in the body, or could we do better than aspirin ticagrelor, perhaps giving clopidogrel and rivaroxaban 2.5 PD, those kind of thing here? Because I was really surprised to see a stent thrombosis after 4 months in this case. So are we addressing the proper issue? We have made a more thrombogenic milieu now in the body, in the stent, in the artery.
No, sir, I don't agree with that, because previous stent was undersized. So if the blood flow in coronary vessel is most important factor which prevents stent thrombosis. So the hemodynamic coronary artery has to be improved. Now the stent size is appropriate, though I would have further post-dilated the left main a bit higher, but I feel now the flow will prevent further stent thrombosis. Yes, I agree with your point. 2.5 milligram twice daily of additional rivaroxaban is very ideal for this case, but I'm not sure that can be given along with 2 antiplatelet because the data with aspirin
So
only.
not to antiplatelet, but Arindam, as you mentioned that flow is the most important from thrombosis. Do you think an 80%, 90% lesion with chronic stable angina is liable for thrombosis? Unless the rupture because the flow is limited?
No. In this case, the stent was the problem. That is why he
Stent was
had
the
this.
problem.
That is why he
Stent
had the
was
thrombosis.
giving at least a 3 millimeter flow, may not be 3.5.
No, sir. No, it's
One
not
thing-
like that, sir. It's not like
Beard
that.
starts are
Thessel was-
thrombogenic.
Yes.
See,
That's why stent starts are thrombogenic. It's the straw,
No.
it's not the lumen.
If it is nicely opposed, then it is not thrombogenic, sir. We are doing angioplasty. You also doing angioplasty. So many patients. Yes, sir. Go ahead.
I have
please.
one question. Again, away from the point of discussion. The patient is diabetic. Patient had this type of re-stenosis either because of stent thrombosis or because of ISR, whatever be. Is there any possibility, a second time round, when I saw the patient, is there any possibility of asking the patient to go for CABG?
Exactly. That is what what was going in my mind.
I may get a personal satisfaction of doing something very good, looking so smooth, so nice, so beautiful, but the beauty and nice part of the stent may not remain beauty anymore. Maybe within 7.
What is how do you prognosticate this patient?
Syntax score is very less in this case. At the time of presentation, patient was
Issue is little different. Issue is little different. Issue is we are dealing with a diabetic patient who had a stent thrombosis. Maybe as Arindam is telling, it missed the ostium. There was a bare space, and I agree to that. But now I have made 2 layers of metals. What Shomitra was pointing out, we made 2 layers of metals in a diabetic patient involving the left main ostium to a mid part of the LAD. Well, how do you feel? How do you compare the outcome vis-a-vis a CABG? That is perhaps Anyanda what he was asking, and this is my question as well.
So I can answer it. Patient was
sure.
presenting with acute coronary syndrome, and as you all know, in acute coronary syndrome, CABG do not have any role. So there was thrombus. Please let me finish, sir. Please let me finish, sir.
I disagree. Anyway,
this is my answer. You can also do whatever. So acute coronary syndrome. I have seen many surgeons. They will not operate the case until and unless the tropi is normalized. Now, if the patient has
you have to look at the coronary artery.
Let Arindam complete. Yes, otherwise, we get a part of his view.
Yes. Anyway. So if the tropi as the presentation was there, I think if the quantitative tropi is done, it will be very, very high. Now, if the CABG procedure is delayed, how can you ensure that the patient will not have another event in hospital? That is question number 1. And question number 2 is we do always have option. In fact, in this kind of my cases, I do a routine angiography after 6 months. And if I find whatever strategy we applied, that is not successful, we can go for bypass surgery at any case. Fine. Routine angio after 6 months.
So you want to take another chance?
Yeah.
Yes. This is SCS, sir.
Yes.
Another chance.
I would have agreed with you had it been a STEMI, but I have not seen the ECG, nor do I have the trop reports.
Sir, tropi was positive. Tropi was positive, and it was STEMI. Patient is having chest pain just 7 days ago. Now patient.
You didn't show the Shupratip this. Then I will say this is an incomplete presentation. Had it been a STEMI, this question won't come up. Because in a case of a STEMI, certainly you need to open up the vessel first. Had it been an NSTEMI, you can have this patient with an NSTEMI as well. And in an NSTEMI, this is not mandatory that you need to go immediately with this thing. That depends.
This is not NSTEMI. This is again stent thrombosis, and EF has also dropped from 50% to.
Oh God!
STEMI is diagnosed.
Stent thrombosis and STEMI things are not same. That is the difference.
Yes.
Okay.
STEMI is not diagnosed on the basis of stent thrombosis or chest pain or even risk factors. The only diagnostic tool for STEMI is just simple ECG.
And show the ECG. Do you have the ECG with you?
Yes, I am
You did make a slide.
not in the slide.
What it was?
ECG was not presented.
It was ST elevation in V1 along with biphasic T in V2 through V6. And one AVL, there is mild ST elevation with T inversion.
Dr. Banerjee was mentioning something. Dr. Banerjee, please.
Shubhra.
Firstly, I don't agree that that there is no cause for stent thrombosis was evident. Of course, there is an underexpanded stent, and we know about all the parameters, be it stent malapposition and whatever. But stent underexpansion is a very important cause for MACE, and that can cause actually stent thrombosis. So that could be one reason. Secondly, coming to that very important question, which Anjanda and Chandrada, both of them have been saying, like, what about, and Shomitra actually raised it, that what about rather than putting more metal in a place, in a patient who is probably could be thrombogenic, why about thinking about bypass surgery? Well, this was a case of under expansion. If you accept that, and if you have expanded the stent, I wouldn't really think about any additional thrombogenic mechanism here. So I think I would be really happy to put in another stent. However, had this been something where we can't explain and the patient, and of course, one thing I would say, I would definitely tell the patient that there may be an increased chance of stent thrombosis or ISR once again. And if he's happy to go with that, I will do it. Otherwise, there would be an option for CABG, and I think it would be right to discuss this with the patient as well, rather than simply putting in another stent. But we can put in another stent, and we are perfectly all right to do that, I believe.
Any other comments, questions, anything?
I have one question.
Yeah. Carry
on. Shotten is having some question.
Shotten, please.
I was regarding the stenting strategy. I want to ask Supradeep and Arindam whether we could have post dilated the distal most part of the stent with a larger size balloon and stented the left main to LAD proximal part, so that we get a balance of metal burden as well as covering the left main LAD ostium and the left main plaques. Thus, we can, rather than using such a long 38 3.5 stent, which there is a over dilatation in the distal part of the stent. The distal most part of the vessel is diseased, and there is always a chance of distal dissection as well as slow flow. We could have balanced it with a smaller stent using covering the left main to LAD ostium or just proximal part, and post dilated the distal most part of the stent. Could have and if we can get a reasonable result, we could be happy with this. We could have avoided using such a long stent in this patient.
So then distal most part, in the distal most part where the stent was placed, we have placed also a 4-sized vessel, number one. And will you feel safe if you leave those distal part by just dilating with the balloon?
And, yes, because there is nothing inside the stent. Everything was under expansion and malapposition.
But that stent is under expanded. And
yes, if I get a nice apposition after post dilatation with a larger balloon, if I was shows that we got a good apposition, got a good lumen area after post dilatation.
And another important thing, I feel the first stent was in a plaque in the mid LAD. I don't feel
maybe,
it
but
there.
But
let me finish. Let me answer you. So basically, see, as Supratik also mentioned, he could not find any features of plaque rupture or plaque erosion. So we were not sure what part of the stent or what part of the artery actually created the thrombus. So when you are post-dilating a stent which was implanted 4 months back, it is obvious that it will be definitely epithelialized. So what you are doing, you are again creating raw surface. So you have to cover it. There is no doubt about that. You need to cover the entire existing stent, and that has to be done. There is no excuse, because in this kind of situation, which the modality which can actually pick up the microaeration or plaque rupture OCT you cannot do because of high thrombus burden, and it is not advisable. IVUS is the ideal choice here. And as you are post expanding 4 months previous stent implanted, that will create raw surface, and you need to cover that with a drug-eluting stent.
Also, the ostial left main may be a problem with OCT.
Yes.
So that's the reason.
Yes.
IVUS is better here.
I have one question. What should we do with LCX? Should we check for whether there is any gel strat or not?
No, it is not indicated. Your angiography did not show any kind of pinching, and you did a stenting IVUS pullback, which showed that the LCX ostium is disease free. So nothing to be done with LCX. Only issue I would, in fact, would like to take the opinion of the senior. Your gelled LCX wear, at what point of time you are going to take it out? Because recently in our lab with some other operator, we seen that a long, trapped gelled wear, when it was actually being, taken out, the stent actually came out with the gelled wear. So this is a big stent. You are, going at a high good pressure inflation. So at what point, whether you are going to take out the gelled wear before the stent being deployed or after stent deployment, that opinion I would like to have the opinion of the seniors. But LCX nothing to be done post stenting. It was fine. You can do FFR if there was significant pinch. You have the option of doing FFR, but it was not needed in this present case. So, Dr. Banerjee, at what point would you take out the gelled wear of LCX? Before the implantation of the stent or after the implantation of the stent?
No, after the implantation of the stent.
That is the common thing we do,
yeah.
But recently Shomo had a problem. So the stent, it was an Indian made stent, and whole stent actually came out. In fact, got crippled, and ultimately patient had to be sent for emergency bypass surgery. It was so bad.
That's unfortunate, but I actually missed the last part of that case. I mean, when it was shown, but what was done? Was it a side and pot done? Was a kissing done, or nothing?
No. LCX was not done. Nothing was done.
We haven't done anything.
There was very good flow. I don't think there is anything to be needed in LCX ostium.
But some people would do at least a side.
Final kissing.
Side. No, not if some people go for a kissing. I've seen some people would go for a side. I mean, without kissing, just as you do the pot and the side and then a pot. I mean, pot side pot in the sense like you just do sarcostium with a pot. And some, which I prefer not to do anything if the flow is fine. Because some do a side, just dilatation of the side branch, because they think that the strat may fall across the circumflex ostium, and that can cause problem later. But this is an important thing. I don't know what you do. I mean, this is a question.
I think pot is the mandatory thing. You need to do a pot. That is for sure. Now, rest of the thing are not mandatory, and it varies as per the operator's choice. So it's okay. Whatever. If the flow is good, you can do whatever you want.
In this case, I have done pot in the LM, and then I have the thought whether I have missed to see whether there is any strat across the LCX or not. I have missed that part, but I haven't done anything because LCX is having good flow. So, sir,
what size balloon you took for pot? Because this is important. You need to have whenever you are doing a left main, you need to have a very small size, small length balloon.
It is 4x10 balloon. 4x.
So as you cover the left main ostium, then it is not a problem because you can hang the balloon even beyond the ostium. But if you are not covering the ostium, this is a mandatory requirement. Whenever going for this kind of distal left main covering, you need to have a small balloon for pot. You need to arrange that beforehand, because otherwise it will be very difficult. In your case, you cover the left main ostium, so it is not a problem, the length of the balloon. But if you do not cover it, it is very, very important to have it beforehand, a very small size for 6 millimeter kind of balloon, length balloon.
Okay, any other questions or comments? If there are none, because Shomitra and Shubhra has already hinting that they will be leaving. So if any comment from anybody or any question, otherwise we call it a day. The next meeting will be 2 weeks from today, and one speaker is Dr. Bappaditya Kumar. He has agreed, and the second speaker I will intimate you in course of time. So thank you everybody. Thank you very much.
Very nice
coming
cases.
over, and
Very
it was
nice.
two very nice presentations.
Thank you, sir. Thank you.
With very exhaustive discussions. Thank you very
Perhaps
much.
I'll suggest everybody again to refresh our knowledge and latest things about the physiology of endothelization, thrombosis, POBA versus bare metal stent versus drug-eluting stent. Why they evolved, why we are using those one over the other, what is the main purpose. Perhaps we are a little confusing. So good luck, we'll discuss next time.
This type of cases will be presented so we can discuss in our future cases as well. Thank you. Thank you everybody, and good night.
Thank
Bye.
you.
Good night.
Good night.
Good night.